Andrew, we've got about 40 people online, so I think we can make a start.
Thanks for that, Karen. So welcome everyone to today's presentation on the compelling case prevention findings and insights from the GoHealth model. It's my pleasure to be coordinating the show this afternoon. I'm Andrew Wilson. I'm the co-director of the Australian Prevention Partnership Centre, and filling in for my co-director, Lucy Rechnick, who has unfortunately been struck by the dreaded COVID. Just in starting, I'd like to acknowledge the traditional owners of the various lands on which we're all gathered today, spread out across the nation, and acknowledge the contributions of elders past, present and futures, and any Aboriginal or Torres Strait Islander people who may be joining us for the presentation today. Our simple format today is in line with that we're going to hear from the team about the project, give you a bit of an overview of the project, and then ask a couple of the other key people who are involved in the team to address some questions. We will also try and take questions from you as well. You can put questions into the Q&A function and I'll keep an eye on those, and depending on time we'll draw on those, but we'll also try and answer them online as we go. So let's then get down to the business. Joanne probably doesn't even remember the origins of the Prevention Centre work in the modelling area. Now going back some 9 years, it goes back to a conversation that Professor Sally Redman, Joe and I had about, and we were really focused at the time on the issue of knowledge translation and how we brought different bits of information together. And I posed the question that most of the techniques that we're familiar with and using were about synthesis of formal evidence, of synthesis of evidence that came from research, from quantitative research, from meta-analyses, systematic reviews, those sorts of things. And I posed the question, but what about all that other information that we need to bring to the decision, into that decision-making process? And we pondered that, and Jo went away, and she came back, and she said, well, I've just sort of been introduced to some of these ideas in modelling, and I think this might be a way of doing this. And out of that has grown an extraordinary program of work using different types of modelling to inform decision making in the prevention space. And one of the projects that we've had really on the cards from very early on the piece was to sort of try and have a unifying model, a way of trying to bring this together. And the team has worked on this and over a period now of almost 6 years in bringing this all together. It's an extraordinary effort that's involved an extraordinary range of people, and in particular the people that are identified on the screen there who are part of the project team. So this is a really fascinating and an exciting journey for me to see this coming to fruition. And I'm really pleased to be here today to hear Danielle as she gives us an overview of the model on behalf of the project team, and then to hear some of the comments that go with it. So let me then introduce Danielle. So Danielle is the systems dynamic modeler with the Sachs Institute. She came to us originally from Queensland. She with a background in environmental management and public health, and has developed an incredible expertise in a relatively short period of time in the health area. The number of places I now see Danielle presenting is just extraordinary. The topics that she presents on is just amazing in terms of the range of topics that she's covered. As well, today I'm joined on the program by Joanne Ochapinti, who's the head of systems modelling and simulation at the Brain and Mind Centre at the University of Sydney. And as I've indicated to you, somebody who's been on this journey with us right from the start. And then an old colleague of mine from the University of Queensland, Steve Begg. Steve's an epidemiologist, long-standing, been involved in work like this for quite a long period of time. He's currently the director of the Violet Vines Marshman Centre for Rural Health Research at La Trobe University. So both of them will be coming on after we hear from Daniel about the project. So Daniel, over to you.
Thank you so much. And I also have to introduce my colleague Jackie Davison, who's with me here. Am I on? Yep. Who will be sharing this presentation with me. And Jackie's also been on the long journey of this particular project. And thanks for that great introduction, Andrew, who's set the stage and there's a lot to live up to. So, and there's a couple of other members of the project team that we also should acknowledge who've had some great contributions over the period of this project. And so just to kind of move on to what the purpose of this webinar is. So what we are hoping to achieve in this webinar or get across is we want to describe the context of this project and provide an overview of the model that we've been building. But mainly what we're looking at is outlining some of the key insights generated through the model development and experimentation that we've done. So instead of focusing on really the hardcore mathematical outputs, we really want to focus on what are the things that we've learned through the process of making this model and what are the policy implications of those things that we've learned, because there's been some really interesting policy implications. And then broadly, we want to more broadly discuss the potential policy uses of this type of tool, as well as the data environment improvements that will be needed to support public health modeling or population health modeling as a whole. So this is us going along the journey from this idea that we had of modeling all the way through to producing a simulation model at the end. And so Jack's going to give a bit of background on the product itself.
So, as many of you on this call will know, the AHW provides, up to date, provides researchers and policymakers with the best picture available to us on the impact of diseases and their related burden. So it tells the story of the types, the scale of preventable illness and death, and gives us a reasonable estimate of causes. And to produce these burden of disease studies, there's a range of well-covered hospitalisation data and mortality data is used. However, to understand risk factors, the use of population surveys is generally used to quantify risk exposures from environmental to biomedical and behavioural, also called modifiable in this particular presentation. So together they paint the overall description of a growing disease burden, which if you follow the disease burden studies over the past few years, you'll definitely see that that growing, and particularly the preventable proportion of chronic disease burden more specifically. So we also have used, we know that policymakers use a lot of that data to inform their own policy targets and indicators, and some of that's domain specific, and some of that is quite risk specific, and some of these turn up into policy documents from the obesity strategy, smoking strategies, and most recently, many of you will be familiar with the National Preventive Health Strategy. So lots of these targets and indicators for reduction or increases are singular and are not often combined together. But what if we could use models to understand how those combinations and targets can be addressed, and we'll understand better the relationship of each of those targets and indicators with each other, their relationships of risk exposures themselves, and the relationship to the projected burdens into the future. So, as Andrew's already pointed out, the idea of using systems modelling methodologies to capture some of these complexities of the modifiable risks and its related disease burden sort of became much more. The capacity has certainly grown, certainly within the Sachs Institute and more broadly across Australia and internationally in the recent past. So we hadn't the idea and this project was generated to use system dynamics to bring these complexities together and their related disease burden. So the idea originally was to produce a tool that policymakers, of course, could use to capture these risks and burden and the risks themselves and the related burden. Sorry. Yep.
So basically, given that we have this kind of understanding, or there's historic information about these risk factors, as well as we know now that there's these links between risk factors and diseases, we really thought, could a simulation tool be useful to help us, based off of the data from the past, help us look forward to inform these decision makers, these decisions. So really, because we're a group of modelers, we asked ourselves again, can we capture the complexities of modifiable risks and diseases using system dynamics, which is a modeling technique that we have? And then if so, what could simulation modeling tell us? And then, ta-da, we came up with the GoHealth model. And so if we look into what is this GoHealth model, it looks a bit like a spaghetti diagram here, but there's some kind of main components that we have. So we have 9 key risk factors that we looked at. And we look at how those 9 risk factors interact with 16 different diseases. And we chose the diseases that are most linked to the modifiable risk factors. So this isn't all the diseases, obviously, that pose a burden to the Australian population. There's some things like low back pain and dementia that were not really closely linked to these particular risk factors, and so they weren't included in this project. So it does have to be kind of looked at in the context of, we were really focusing on the risk factors, the most prevalent risk factors, and the diseases that have the biggest burden associated with them. And then when we kind of combined those together, we looked at, well, what is that burden? And we didn't just look at the burden from a health perspective. We also looked at it from an economic perspective. So both in terms of cost to the health system, but also things more broadly, like changes in productivity and absenteeism and workforce participation, because we know many of these diseases have a huge impact on that, which has an impact on Australia as a whole. And lastly, we couldn't do this without looking at the changes in the demographic makeup of the Australian population. So we know it's changing. We know we're getting an older population, and we know that we have varying levels of immigration and emigration. So we thought it was really important to capture how those changes impact the changes in the risk factors, which then go on to change the burden of those diseases, and then the combined burden together. So really, with the GoHealth model, the key objectives of the model was simply to build the system dynamic model that included the range of risk factors that contribute to those diseases, and then to use the model to help inform public health community to make a more united and compelling case for prevention and chronic disease prevention.
Yeah, so to start with, before we started modelling, of course, we needed to do a lot of data gathering, and for this particular model, as you can tell, as Danielle's outlined, the scope of the model is significant in terms of both the numbers of risk factors included in this model, 9 if we separate fruit and veg out into 2 separate dietary components, and the numbers and the diseases themselves, which is 16, and related healthcare costs, hospitalisation costs, mortality costs, and then other related economic costs, including productivity losses for each of those diseases. So as you can see from that, it's a formidable amount of data, and particularly we're looking at gathering together as much historical data as we can to be able to inform trends for the future. So we needed to provide, as much as possible, make it a nuanced model to reflect the ageing population. So as much as possible, we needed 5-year age group data and a sex split of that data. Of course, we need to produce use as many standard epi statistics as possible that we have available, and of course we use the published relative risk and population attributable fractions produced in the ABD and the global burden of disease studies as well. We also need to be able to find and calculate. We can go on to use. We need to be able to use and calculate missing data, because obviously for that amount of diseases, that an amount of risk factors as well, there are data is particularly data missing. So as I said, we used the risk-specific data sets from the AHW, including and ABS survey data from a number of population health surveys, household alcohol drug surveys, etc., and the annual global burden of disease results tool. And we also used to calculate that missing data and find that missing data. We used a little known tool, but very valuable, published, I think, by the WHO, an epi tool called DISMOD 2, which is used by both the AHW and again by Global Burden of Disease when as a sort of a calculator, if you like, to fill in missing gaps in EpiStats.
So it comes to the part of how does the model work, and this is the part where I usually tell people to buckle their seatbelts because I'm about to take you on a journey. And so it really starts off with a general premise of we have a bunch of data and we want to look at the data from a historic perspective. So winding the clock back and seeing how the data has changed over time. And we use that to create a number of oh, stop. Oops.
Go back.
It's releasing all the secrets. So we do that to create the base structure of the model. And then what we do is we use the population characteristics of, it's automatically rolling itself out. See if I can go through it's quite a complicated. So we have the base model that we have, and we use the demographic characteristics. Well, we'll have to go really fast. Of the population. And well, I'll just let it run out and then I can go backwards. Please hold. Oh no, don't go to the next slide. Oh, you're just yeah, there we go. So we use the demographic profile of the population with Australia to create distributions of the different risk factors. So if we use the risk factor that we have here, for example, this is looking at cholesterol, so total serum cholesterol in the population. Sorry, PowerPoint is out of control right now. A total serum cholesterol in the population. We create these distributions that look at what is the risk across the different prevalence levels. So for each percentage of the population, what level of cholesterol do they have? With there being a threshold of risk where above that threshold the risk exists, and below that threshold, sorry, it's automatically animating, below that threshold the risk doesn't exist. And we then take this information and bring it up to this section here where we start looking at it at the disease level. So based off of that distribution of risk, how much of the risk does it pose when in the context of a specific disease? So we've taken this risk, PowerPoint is gone crazy on me, and map that across the intensity of the risk factor based off of how much risk it poses. Obviously, the more risk the more intense the prevalence of that risk factor, the higher the risk it has. And we then bring this in to ask questions like, how much of that risk, oh, I'm sorry, folks, how much of the risk that is present in a population can be attributed to that specific risk factor? So we then kind of look at it at a number of steps. We look at how much of the risk comes directly from high cholesterol to, for example, ischemic heart disease, as well as what portion goes through other risk factors, as well as lastly, we need to control for the effect that the cholesterol has on other risk factors. So a portion of the risk that we would have attributed to high cholesterol is actually part of the risk that comes from high blood pressure. So there is an overlap in the risks that come together. And so we then take this calculation and do what PowerPoint wants to do and bring it to the next slide. And we get all of the risks that are attributed to all the different risk factors for that specific disease. And we combine them all to calculate the contribution of all of the relevant risk factors to that disease, which we bring this down here, which then lets us calculate the incidence of the disease, the proportion of the disease that's the proportion of the disease the prevalence of the disease, sorry, that is affected by aging. So as people age, they will circle through the model, as well as I'm sorry, I don't know why it's automatically animating. We account for things like remission, people dying from and with disease. We then combine that together to calculate the amount of the disability that's caused by that disease. And then that gives us the combined disability attributed to that disease. And then we do what PowerPoint wants, and we bring it down here, and it gives all of the sequelae for that specific disease. So this tells us how much burden there is for ischemic heart disease, but that's just one of the many diseases we're accounting for. So we then take this calculation from that one disease, combine it with all the other diseases for the economic measures. So we look at the health burden, which is measured both in the years lost to disability and the years of life lost to premature death, as well as the more kind of economic and cash-based ones for things like direct health sector costs, as well as productivity loss, workforce participation, and absenteeism. So it allows us to go all the way from the prevalence of risk factors in the population to calculating how much of a particular disease does that risk factor contribute to, and how does that change the prevalence of that specific disease, and then trickling that down to how does that calculate the burden of the disease. And I apologize for the animations. I don't know why it's out of control. So from there, let me just go from there. That kind of gives us our final measures when we're looking at the burden of disease. And so if we think back to the purpose of the webinar, it was really to focus on specific modeling insights we got through the process of making this model. And as Andrew mentioned, it's been a long process making this model. It wasn't something that was built overnight. And there's a lot of learning that happened throughout the process. And so again, we have me here with our idea of the models, and then we have the goal at the end. And so the first kind of a thought that we had was these 4 insights. So the first one, was the need for consistent and reliable historical risk factor trend data to learn from. And so we, in the very famous words of Maya Angelou, you can't really know where you're going until you know where you've been. And so that was something that started to ring really true as we were building this model. That when we look at the data that was needed across each of the different risk factors, because if you remember, we have those population, the amount of risk that exists in the population. In order to calculate that over time, we need quite a few data points that are consistently measured, as well as our age and gender minimum, age and gender separated, so we can see how it's changing over time as the Australian demographics change. So if we have some of our key risk factors here, we can see that across some of them, we had very few data points. So for example, for total serum cholesterol, the data that we were able to get was not gender stratified, it was age stratified, but we only had two good years of data. And as many of you will know, 2 data points a trend does not make. It's very difficult to say, how cholesterol is changing in the population based off of 2 data points. So we quickly ran into the issue that we didn't really have a good understanding of where the risk factors had changed, or how the risk factors had changed in the past. And this was really disappointing because there's really good disease data in Australia. We collectively have a very good understanding of how disease prevalence has changed. But then when we kind of think back to what is causing a lot of this disease, or what is contributing to a lot of disease, we really don't have good data. That data hasn't been captured on how that's changed. And it's very difficult to make decisions and to build a simulation model if you don't have good data to build from. And so, for example, what we did is, if we look at the annual change in the percent obese across the different age groups, we modeled a couple of different scenarios. And so one of the scenarios, the 3 main scenarios we have is to continue the rate of change, is almost pretend as if you drew a line between 2011 and at the end 2017, the rate at which it's changed over time on average, and we just continue that along. We tried another scenario where we looked at the rate of change in 2017 and just froze it. So there was no more change after how much obesity we had in 2017. Or we tried, well, what if we taper it off? What if we, slowly work our way back until the percentage of change in obesity drops down to nothing? So we just tried 3 hypothetical scenarios because, again, we didn't have very good data on how some of these risk factors were trending. And so if we look here, this ends up being the percentage of people who are obese between the ages of 25 and 29 who are male. And across these 3 different scenarios, we get 3 really different answers. So it could vary anywhere from almost 30% of the population being obese to something more like 22, 23%. And so if we don't know where we've been, we don't know where we're going. And so if we translate that to the whole population with those 3 trends, and we aggregate all of the age groups together, we have that same issue. Whereas it could be somewhere between 30 and 40%, and that's huge when we think of how that trickles into the effect of obesity on diseases. We don't really know, we don't have a good sense based off of these few data points where it is going into the future. And so we need to measure more data points before we can have a tool like this can be fully useful to inform decision making. And I should say that we've used obesity here, but obesity is probably the risk factor that has the most amount of data. So if it's difficult to do from a perspective of obesity, it's far more difficult to do from especially the biomedical risk factors that need to be measured, like cholesterol and blood pressure, that require an actual measurement, particularly done by a clinician or such. So that was the first kind of learning we have. So what's the kind of priority for action?
Oh. That's me. So for each of these insights that we've discussed and prepared for today, we've sort of thought about what does that mean for from a policy point of view, which is most of the audience, I think, today in this webinar. So certainly it's highly important that we've aware of the National Data Framework for Prevention that has been outlined and highlighted as a really important part of the new National Preventive Health Strategy. And so implementing that framework, which I don't think is fully articulated yet, is really important to have this kind of background about what are the priorities of the risks in terms of data capture, the ones that have so-called been ignored in terms of good, consistent, defined, and well measured data points historically that can be supported or improved upon going forward in order to support the aspirational goals of the new strategy. And some priorities might be the consideration of some catch-up data for specific risk factors that have been identified.
So the second thing that we always one of the learnings or insights we got from this is the need to always measure the broader impact. So there's really we notice a strong importance for comprehensively measuring impact. So if we have a chord chart that looks at the different risk factors that we looked at, as well as their contribution to the different diseases. And so you can see that many of the risk factors contribute to many of the diseases being considered. And so we often or historically have done the one risk factor, one disease kind of evaluation. So we would look at, what is the effect of smoking on lung cancer? And when we do that, we're really cutting ourselves short as a public health community in that we're undervaluing the measures, because even though it may be done in the name of lung cancer, interventions or initiatives to reduce smoking will have trickle-on effects to a number of diseases. So if we look at BMI, for example, BMI has a connection to many different diseases, include chronic kidney disease, colorectal cancer, ischemic heart disease, liver cancer. It goes on. And blood glucose is very similar. So we think of blood glucose in the context of diabetes, but it goes far beyond that. So we're cutting ourselves short in terms of our evaluations if we take an approach of only looking at the one risk factor, one disease model of evaluation. And so the kind of policy and practice implications of this is that the complexity of the system kind of requires us to look at all relevant outcomes that need to be acknowledged in the reporting of the effectiveness of our interventions. And considering only the intermediate or narrow benefits really underestimates the impacts on the system and makes it so that we're underselling the really important work that's happening in prevention, and that using system models can really help accommodate for those connections. But that comes with a caveat, and that's going to be our third insight, which is overestimating the impact of risk factors is really easy because they're not additive. Most of them are antagonistic or have an overlapping effect. And so hopefully this one won't go too fast. But in this particular case, what we were looking at before was what portion of the risk that is present within a population can be attributed to cholesterol. So there's a portion that we can attribute to cholesterol, but then we also need to control for the effect that other risk factors have on cholesterol. So for example, diet and exercise and blood glucose have an effect on cholesterol. It can lower or raise your cholesterol. So we need to account for that. But more importantly, we also need to control for the effect that cholesterol has on other risk factors. So a portion of cholesterol's risk is actually captured in the risk for blood pressure. So it in and of itself isn't creating the risk, but the fact that high cholesterol can contribute to high blood pressure creates the risk. And so you have this overlapping section. So if we were to do an initiative and just measure the effect of a physical activity or a BMI effect on cholesterol to ischemic heart disease, we would actually be overestimating how much of it we can potentially change, because we would be double counting the amount of risk prevented here. So that's really important to know. So if we kind of look at that same graph we were doing before, but we've combined all the diseases together, and if we treated them like additive, treated their risk factors as additive, it would look a bit like this. But in reality, it looks more like this. So because some of these risk factors overlap, the amount that we can change is actually smaller than what it looks like if we were to treat them in an additive perspective. And there's this kind of unrelatedness to things that we can't change. So there still is a large portion of the disease burden that we can change, but these overlap in a way that needs to be accounted for. And so what are the policy and practice implications? Well, we really need to make sure that we're applying a really critical lens to evaluation, and that when we're considering the impacts of modifying one risk factor without considering the effects of that burden on other risk factors, we're likely overestimating the amount that we can change in that single kind of just by targeting one risk factor. So it also kind of brings to the mind that traditional analytical tools that we use to prioritize risk factors for public health have important limitations when applied in the kind of more comprehensive chronic disease prevention space. So we really need to be careful and look more comprehensively, both in terms of looking at the benefits of our work comprehensively, but understanding that risk factors overlap and they create a combined burden that has some overlap that we must account for. So really targeting just a few risk factors isn't going to do it. We need to make sure that we target across the spectrum of risk factors to capture that space that's been overlapped. And lastly, the kind of really interesting insight that we came to is targets for change really need to capture the underlying different trends. So models are really good for that. But what do we mean by that? Well, the things aren't all moving in the same direction. So this graph we have here is looking at the percentage of the population, or the population that's hypertensive, so with their blood pressures over 140, as it changed from 2011 to 2017 across the different age groups. And if you kind of look at it, you can see that some of them have a downward trend, some of them have an upward trend, and it changes, by age group. And so if we just kind of think collectively that people's hypertension is going down, that's a nuance that it's missing the nuance that it really depends on the age group. And we have to consider that Australia is aging, and that initiatives that may have had success targeting younger individuals may not have the same level of success, or may not have the same longevity as previously, because the demographics of Australia is changing. So really, when we're looking at the effect of our interventions, we need to look at it in the context of a very changing population where the effects of initiatives has different effects at different levels. So this also added to the complexity of modeling it. We couldn't simply model obesity going up and blood pressure going down, because it really is nuanced at this individual level. So if we don't capture the data and our understanding at this individual level, we're kind of incorrectly capturing how things are changing in Australia, and we can't project forward. So the policy and practice implications of this is that fixed targets can really miss the potential counteracting trends that exist in the population. So we really need to make sure we're counting things at a much more nuanced level. And also, by surfacing these micro trends, or these trends in different demographics of the population, it can really allow for more better and improved analysis of the data and understanding of the situation. So really, where are we now? Well, we're at this partially illuminated world. So there's a partial illumination of the path to get there. But because we really have hit this brick wall of lacking sufficient data to create strong underlying trends, what we've done is we've created a great architecture for a model that has great potential in the future to provide some really important decision support for policymakers. But now what we need to do is back this up with having some more robust data about the risk factors. So we were in this situation before where we thought, if we look backwards, could we look forwards? But actually, we've now realized that looking backwards is far foggier than we thought it would be. And so it really makes it very difficult to project forward until we know more. But not all hope is lost, because within the National Preventative Health Strategy, there's a number of initiatives, or a number of strategies to try and help us get more robust data collection and understanding of the risk factor picture that is in Australia.
And hopefully that framework that's promoted in the strategy will allow and support the improved measurement and consistent definitions that are really important to produce and understand the historical, certainly historical and moving forward data that we need to produce a model such as this, and update a model. That's an important thing for it to be used. It'll need to be updated regularly, and going forward, that regular data collection is vital to do that.
And so kind of in conclusion, the first one is the one that has really struck me the most in the process of building this, is that quantifying the intricate connections of preventable disease is really important to understand the system, but it is so complex. And we have this expectation that decision makers will somehow be able to do this in their head. And really, if it takes kind of many steps and 3 years of data crunching to get to this point, it's really kind of an impossible task for decision makers to be able to really understand the implications of risk factor prevention strategies and how that trickles down into diseases and then onto burden, to be able to calculate that all in their head. So we need tools like this, like systems modeling. It can provide a really important tool to help capture that, because you really can't do that just in your head. And so we currently have the tools to do that, but in order for us to use them, we need to have better data to feed into a model like this, so that the architecture exists, the concepts exist, the model exists. Now it's just waiting and begging for this new data to come. And so we do have disease and cost data, and there's been so much investment in understanding diseases and costs but there really hasn't been that same degree of investment in risk factors. And until we have that investment in understanding the risk factors, we won't be able to progress to a really strong, robust preventative strategy in Australia. So again, we especially want to thank the Prevention Centre and all of its funding partners for helping make this work, possible. And we hope that we'd be able to continue it and grow it as we get a better understanding of the risk factors. And I think I'll use that to segue back to Andrew to go on to our discussion about where to from here.
Thanks, Danielle. Thank you, Jackie, as well. I did fail to acknowledge Jackie at the beginning, and while singing the praises of Danielle, I should just add that Jackie has actually been there longer than Danielle. And shortly after Joanne set us on this journey, Jackie joined us and has been a stalwart and across the whole program. So it's great to have you with us too, Jackie, presenting. Just before I go to Joanne and Steve for comment in relation to this, there in the questions, Morella has asked, she says, amazing piece of work, very nuanced. Is it possible to disaggregate the data to calculate risks for target cohorts as well as the whole population?
That's a great question, and it's one of the things that is in the goals of this particular project. But because, again, as we mentioned, we struggle to have that disaggregation in the risk factor data consistently across the portfolio of risk factors. I think the outputs the model does produce outputs that are disaggregated by age and gender. Anything beyond that has been really difficult in terms of getting good data. But I think as this progresses along and in future iterations of this, as the data is updated, I think that would be something that would be a reasonable expectation from this sort of model. So it's still kind of stuck at the lack of comprehensive risk factor data, but I think it's something that would be possible in the future for sure.
Thanks, Danielle. Okay, let's then go to Joanne and Steve for their comments. So, Joanne, would you like to open? What lessons overall do you think we can draw from this work, and what do you think we've learned from rapid deployment of national and state COVID modelings, etc., that might be applied to chronic conditions?
Thanks, Andrew, and thanks, Danielle and Jackie. It's an incredible amount of work, and to take your advice, Danielle, I'm going to look back in order to look forward. So just to provide some context around why we originally embarked on this work for those that are new to the project. Over the last 7 years, the Australian Prevention Partnership Centre and its policy partners have invested over $2.7 million in the development of systems models, and they're only the projects that I was directly involved in, to inform policy and planning to reduce the prevalence of some of the modifiable risk factors and prevent some of the chronic diseases. But tackling different risk factors or different disease outcomes separately, as Danielle mentioned, doesn't allow us to consider how best to invest across the portfolio of risk factors to achieve the greatest impact. So this study really aimed to put together that big picture on prevention and capture in a single model the interacting modifiable risk factors and their dynamic impact on the trajectory of chronic disease in Australia. And when Rob Carter and Andrew Wilson and Jeff McDonald, Mark Heffernan and I first envisaged this research, we were hoping to use the model to run scenarios that would help us understand quantitatively what's likely to be the best overall strategy for reducing the burden of chronic disease over the next 5, 10, 15 years, and asking, is it better to take an incremental comprehensive approach and aim for, say, a 5% improvement in the trends across all of the risk factors, or should we be making a more substantial and focused push on particular categories of risk factors like substance use or diet and physical activity, or the medical management of precursors to chronic diseases like high BMI, blood pressure and blood glucose? But as Danielle showed, unfortunately, the consistencies in the availability of the national data across the risk factors, and therefore the variation in results based on the alternative assumptions that we needed to make on the risk factor trends, meant that we couldn't reliably answer these questions, which was in a way very disappointing, given the amount of time invested and the blood, sweat and tears that Danielle and the team have gone through. But what Australia does have now is an advanced chronic disease decision support infrastructure ready for deployment to answer these and many more questions once it can be coupled with a more robust data ecosystem. And to answer the second part of the question, Andrew, about what we can learn about the rapid deployment, say, of COVID modelling, I think the key advantages for the infectious disease community, modelling community, have been that the decades of investment in pandemic preparedness, in growing the modelling workforce and research portfolio, as well as having in place national infrastructure for infectious disease surveillance, has really helped them to rapidly deploy models to answer policy questions in a really responsive way. And the COVID-19 response was underpinned by various pieces of Commonwealth and jurisdictional legislation, including the National Mental Health, I've got mental health in the brain, the National Health Security Act of 2007. There's the Biosecurity Act of 2015. There's a Public Health Act that Queensland has from 2005. And these have enabled national surveillance and data sharing to support modelling, simulation and rapid response. And so the question is then, how do we build a similar modelling workforce, physical infrastructure and legislative environment to support the modelling of chronic disease and risk factors in this country over the next 5 years? So I'm ending with a question.
Thanks, Joanne. I'm certainly not about to leap in to try and answer that one. Steve, you have had a long association with this type of work, and have been able to observe it but close up for a long period of time. How can national data ecosystems be strengthened to support risk factor surveillance, to strengthen systems modelling-based decision tools? And what sort of agencies should LEA collaborate? And how do we get consistency and sustainability across jurisdictions? And can you solve the other problems of the Federation before we have an election on Saturday?
Thanks, Andrew. Yeah, no problems. Look, I think at one level, we're pretty well served by the data we have in the risk factor space, and I say that because I've worked in other countries where they have nothing. So in a sense, we've got a pretty robust health information infrastructure. We've got good reporting systems in the infectious diseases space. All the modifiable diseases flow through as they should through to national collections. Our hospitalizations flow through to national collections. And a lot of other perinatal data sources, they all flow through and have sort of national standards, and there's a predictability around them. I guess where we fall down though, as Danielle and this model has highlighted, is that risk factors don't have that. There's not a consistent framework for definitions and for collections and for compiling through and feeding up to a national picture. We have national surveys, and they do a pretty good job when they're conducted, but they're only conducted every 5 or so years, 3, 4, 5 years. So there's gaps between them. Definitions change over time, so that's Danielle highlighted those problems. So I think what we need, I guess, is more of a kind of an agreed framework for collection of risk factors. And why I guess it's fallen through the cracks is perhaps the urgency is not there. With infectious diseases, you do need that urgent response. The pandemic has shown that, but that doesn't diminish the impact of chronic disease risk factors at all. We are in the age of chronic disease, so we do need to think about that. That's obvious, but the urgency isn't there. So it's heartening to see a national prevention framework out of which might flow some discussion around these things. I guess the other point is, you know, there are various players in this space. So we have state, you know, there's different ways of collecting risk factors. You know, for the biomedical ones, you've actually got to go and measure them. That's expensive, you know, and that you need to pool resources to make that happen. Much easier is to just ask people, and we do that quite a lot, you know, and you can see that at the state level with all their CATI surveys, for example. You know, they've been going for a long period now. There's a good time series of data around self-reported risk factors, but often that's not good enough. You know, we do know people lie about their height and weight, and they don't know their cholesterol level, and they don't know their blood pressure necessarily. So, you know, it's not the same as having measured risk factors. So you need to put resources in if you're going to get the gold standard in terms of risk factor measurement. And I guess the other point is how we use them. I think what this project has demonstrated is that, you know, you actually need to generate, you know, this framework of assimilating it all into a comprehensive model was a hugely ambitious undertaking. It really was. And hats off to all of you for even conceiving the idea as even possible. But, you know, you've done it. And what I think, just to highlight mine, how I got involved. It was really around the national burden disease picture that AIHW is generating now on a regular basis, and that's all really heartening. But in behind that, there was some gaps. I guess so. My point would be we need to be transparent about these models and make them out in the open, you know, make them publicly accessible, so we know what can be done, and we can have feedback, you know, critical feedback into them. And, you know, that'll strengthen the infrastructure around, you know, how we assimilate all this information and generate these policy tools. So I think that's the other point that we should, you know, think about as well.
Thanks, Steve. I think you're right. I mean, it's easy for us to look at our current data and see gaps. But I well remember back when you were working on the burden of disease, global burden disease stuff, our colleague who was working on the verbal autopsy work to try and even get estimates of mortality rates in countries where these things are not really recorded. I mean, at the time, I thought a verbal autopsy was something a lawyer did to you. You know, so yes, we've got a long way to go to get, you know, to fill some of the gaps, but we've come a hell of a long way, and we're still, you know, as we can see with this modelling, one of the things that you can do here that we haven't really talked about is that when you don't have the data, you can actually make assumptions and test those assumptions in your model to see how that works. And I think that's a really important attribute of modelling. It allows you to look at the value of information as well how much it's worthwhile having better estimates. You know, how much influence that's actually going to have in your models along the way. Leonard Verman in the comments has if I apologise, Leonard, if I'm not interpreting you correctly, but I think he's asking the question that that when we're thinking about benefits in these contexts, we make certain assumptions that those benefits are reflected, that there's a connection between those benefits and certain attributes that may be there, that those causal loop elements that underpin this. But we may not understand those things very well. And I think if I'm interpreting Leonard's question correctly, I think he's asking, you know, the extent to which we can actually investigate those things when we don't have those sort of co-benefits, when we don't have good information on those co-benefits. Do you have any comments on that, in the way that you can, you know, how you can progress that in the absence of some of this information that we're talking about? Steve, Danielle?
I guess from my perspective, the modeling, as you highlighted, Andrew, in the absence of data, the modeling does provide a potential tool to run a variety of different scenarios and use some reasonable assumptions as to where these things may be going and how the effects flow back to one another. So I think the question is, do you think it would be possible? Yes, I think it would definitely be possible to complete the model with some, you know, reasonable assumptions as to where these trends are going. But the amount of sense checking that we will need to do to use those assumptions will be high, because the trends aren't simply, like we said, it's not, you know, the relationships don't exist to the same degree at each of the different, age and gender breakdowns. And if we put in additional layers, like socioeconomic status or cultural background or such, it changes some of those relationships. But I think there's potential to do that. And I think as the model, as we get better data and see where the kind of gaps are that we can't fill with data, I think we will need to start relying more heavily on assumptions and the knowledge of the professional knowledge of the community to say, well, where do you think it's been and where do you think it's going, to make the tool more robust. So we're never going to have all the data, but I think are still a long ways from having the enough data to be able to have a kind of mix of relying on that. But I think it's possible, and I think it's something we'll need to do into the future.
Yeah, and Bradley in the questions had asked a question about the extent about oral health and the extent that given the sharing of risk factors around this, the extent that how this could be extended to the oral health area, and obviously indicating an interest in being involved in that. I mean, my view on this, and I'm interested to hear your views on it as well, is that having built this model, we're actually in a stronger position to be able to look at some of these other, to extend these, and expect, because we're not having to invent, as we have done for all of our single model buildings that I say our, but it's all your work that we've done in all these other areas, for alcohol, for tobacco control in Queensland, for obesity, childhood obesity, where we've built those models essentially from scratch. Here we have a more complete model which can be then modified to look at these other elements in a somewhat easier fashion. I say somewhat because I know how much work goes into every one bit of that. But your views on that?
Yeah, again, from my perspective, I think so. With tooth decay was actually one of the ones that we considered including from the beginning, and I think it was very close to being included. We just need to have some of the more consistent epi data to support the getting the relative risks in relation to all of the diseases. So that's one of the things that's kind of difficult about this, and hats off to Stephen and everyone who worked on the burden of disease studies at the beginning, because there's in order for a risk factor to be added like tooth decay, I think that's or a disease. We have to have it has know that the links to all of the risk factors, so that it's fully measured adequately. So we did rely really heavily on the backs of others who've created those kind of epi channels and the consistent epi knowledge for us to include it in there. And I think that's one that will hopefully be included in the future, and is a really important one, is one that we're particularly interested in. So I think that's, and as Andrew mentioned, now that we have this architecture, we can build off of the learning we've had from the other risk factor and disease combos, and it makes it much easier to add more into the future than had we started from scratch or we're doing individual models.
And Mandy Lee's also asking a question there around the difference, what implications this has for the model from looking. And excuse me, Mandy, if I'm again misinterpreting your statement, but that we look at poor diet as from a componentry sense. So we look at low fruit and veg intake, for example, as a unit, whereas poor nutrition is actually something which is broader than that. And the question of whether or not you can look, at the implications of poor nutrition in a broader sense than through the single risk factor or single dietary component approach that applies in other situations. That we've applied in this so far in the model.
Certainly, the most recent burden of disease work that takes a more granular look at dietary risks and breaks that down a bit further. But I guess, again, it comes back to data. These models are incredibly data hungry, and measuring food intake is difficult. But look, it has been done, and I think that would be a very useful addition to the model.
Yeah, I couldn't agree more. I think when we were trying to decide how big of a piece to bite off, there were some elements that didn't make it into this kind of first round of the model architecture. But as Steve mentioned, now that the AHW's burden of disease has a more granular look at the dietary risk factors, I think that there's potential for them to be added to give a greater look at the data perspective, because it does make it seem like the dietary risks it underplays the importance of the dietary risks, because it hasn't been broken down in that more granular level. There's a lot more to nutrition than eating your fruit and veg, and I think that to do the dietary thing, the dietary topic justice, we will need to include a more granular look at diet as a whole and nutrition as a whole.
There's another question there from Kate Garvey, I think it is, about do the data gaps map to the plans, to other plans such as the intergenerational health and mental health survey plans for 2020 to 24. Should flick that one to you, Joanne. In your other, wearing your other hat. Do you see these things, you know, the data gap, do you see how these data gaps may be filled through some of these other things? You pointed to the preventive health plan. I think Kate's pointing to some other areas where there's the potential to enrich, you know, where we could potentially be seeing further enrichment of the data that's available to fill out the models.
To the extent that they're mapped with the I think that would be an exercise in looking. I mean, Danielle and Jackie have been looking at well, have got a snapshot of where the gaps are in terms of the risk factors. In terms of mapping that against what's mentioned in the action plans, I'm not too clear about. But I think that's a really important thing that we'll need to do. But I also know that like some jurisdictions like New South Wales are starting to explore the legislative environment that needs to be changed in order to facilitate the gathering and sharing of this kind of data. And I think that has to be part of the conversation. And probably I'll just kind of squeeze in my last comment that that really is something that Steve had said and something I've been grappling with for quite some time. You know, since COVID, you know, there's with the infectious disease, you said that, you know, there's an urgency with infectious disease, that there isn't the perceived urgency with things like chronic disease or mental health. You know, that perception that there isn't the urgency is something that I've always, you know, has always grated against me, because, you know, if you're looking at, I think the statistics at the moment are that almost half of the Australian population are living with at least one chronic disease, almost half. And, you know, the cost to healthcare of those chronic conditions has been estimated around $38 billion per year. But there's only 1.3% of health spending currently directed towards prevention. You know, obviously that reflects the lack of urgency, but really we should be creating, as a public health community, coming together and creating that sense of urgency, because it's certainly there, even if chronic diseases are slower moving.
Thanks for that, Joanne. And we might take that as the last statement from the presentation, as that's a very nice summary, I think, of some of the real challenges that we face in the prevention space around this. So let me just close by thanking Jackie and Danielle, but I know they represent just the team of people who have been involved in this, which is, you've seen the list of all the people who are involved in it, and that's only the people who are involved in the most current iteration. And as Joanne mentioned, this has been developing over a long period of time. It's also involved a lot of other people outside of the Prevention Centre team who have contributed to our modelling, modelling exercises, etc., in terms of trying to bring together this information. And many of you who are listed, when I look through the list of participants here, I know many of you have contributed through our workshops, etc., to the building of this in many ways. So I just want to say thank you to all of those who have contributed to this work, either directly or indirectly through their commitment to funding the Prevention Partnership Centre. So thank you all for joining us today, and thank you very much to Jackie, Danielle, Joanne and Steve for presenting.